So this is the fifth session of Delaware MiniMed. This particular series is presented in partnership with our colleagues at Christiana Care. Let me go ahead and, as always, here are our socials, our LinkedIn, Instagram, Facebook, and Twitter. And I need to start adding YouTube here since we're streaming to YouTube live now. We thank all of you who have signed up to follow us. It's greatly appreciated. So this evening, May 8th, we're going to be learning about sports medicine, dance fitness from Dr. Elizabeth Barchi. And I hope I said your last name correctly, Doctor.
Yes.
Dr. Barchi is a sports medicine and dance medicine specialist. She has brought into her treatment process lessons learned from the physical trials of 7 years as a professional ballet dancer. Dr. Barchi attended the Pennsylvania State University College of Medicine, completed her pediatrics residency at the Penn State Children's Hospital, and now, after 4 years of perfecting her craft in New York City as a fellow of primary sports medicine and assistant professor at NYU Orthopedics. Dr. Barchi's work as an educator of dancers, dance educators, and medical professionals is of particular importance to her. She has led wellness workshops for the American Ballet Theater School, the Dance Theater of Harlem, Steps on Broadway, and Mark Morris Dance Center. Sought out by dancers across the country, Dr. Barchi has cared for dancers from the major companies and schools of New York City, including the Alvin Ailey American Dance Theater, the Juilliard School, Martha Graham Dance Company, Paul Taylor Dance Company, Dance Theater of Harlem, American Ballet Theater School, School of American Ballet, Joffrey Ballet School, and the Boychow Ballet Academy, as well as several Broadway shows, films, and television series. And I have to interject the question, have you ever worked with river dance folks?
You know, I have had a couple of patients from the Riverdance show filter in through the Harkness Center Dance Clinic. Otherwise, you know, it was my mentor, Dr. Rose, who actually did the on-site coverage for those shows.
Right.
So didn't get to go backstage, but saw them in clinic.
Between Riverdance and Stomp, I can't think of more shocking dance moves. But in any event, I will stop screen sharing and turn it over to Dr. Barchi. Doctor, thank you for joining us. I am not sure what happened to Dr. Barchi.
There we go. All right. I will share mine.
Perfect. You've got it.
All righty. Welcome, everyone. I am Dr. Elizabeth Barchi, and I will be talking to you tonight about sports medicine and dance medicine. One of them is my absolute favorite. No, I'm just kidding. There we go. I do not have any financial disclosures for this talk. So what is sports medicine? Well, sports medicine is the care of people who are injured during the sport of life. So that can be anything from a professional soccer player, a track athlete, a recreational athlete, a professional typist, and a professional or recreational wood splitter in their backyards. Anybody who moves their body, we take care of them. We're different from orthopedics in that we did not go to a surgical residency. Rather, we all went to some sort of primary care residency. So either family medicine, pediatrics, internal medicine, emergency medicine, physical medicine, and rehabilitation, you name it. Anything that didn't involve surgery, we're eligible for a sports medicine fellowship. So we work a lot on site. If you hear me saying on site, what that means is we go directly to the athletes where the sport is happening. So that's on the sidelines, that's in the medical tents along the route of a marathon. A lot of our colleagues are working directly with the athletes in a training room setting. So we work a lot with athletic trainers. We also work a lot with physical therapists. And I always like to say that the real magic happens in the training room, in the physical therapy room. The physical therapists and the athletic trainers are pivotal members of sports medicine. And hopefully by the end of the talk, you'll see why. In the clinic, particularly at Christiana, we've got a number of things. We can obviously torture you with our physical exam maneuvers designed to cause pain so that we can figure out exactly what is going on. We can also do diagnostic ultrasound, as well as interpreting x-rays, which we'll do a little bit later on in the talk. But we also have motion analysis equipment, so we can take a look at how you move and try to see if there might be some muscle imbalances or weaknesses that could be predisposing you to different types of injuries. And we can kind of help you get stronger so that these things don't happen. And if you're lucky enough to work with me, you can be one of my assistants who is pictured here in this photograph. That's me with my secretary, volunteering to be tortured with various exam maneuvers for a photo shoot. So what's the difference between sports medicine and dance medicine? Well, dance medicine is sports medicine in a foreign country. That means, an ankle is an ankle. However, the way the ankle got injured is a little bit different. And the culture, the language, everything's a little bit different. Just as football is different from soccer, which are both different from hockey and are very different from running or high jump. So all the sports are very unique subsets of culture, and dance medicine is no different. Dancers typically wear shoes just like athletes. Sometimes they don't wear shoes, which is a little different from most athletes. The shoes tend to look a little different. So instead of a cleat or a running shoe, they may be in a point shoe, standing all the way up on their toes. They could be in a tap shoe, pounding, just like in river dance. Or they could be in bare feet. Similar, a hockey player's boot is also very different from a soccer cleat or a running shoe. So every athlete is unique. A lot of athletes will kick a ball. Dancers kick their face or their heads, up to the side. And so the movements are very different between the different sports. And so that will inform you as to where these injuries might be coming from, particularly when we start getting into overuse injuries, which are, very common in dance medicine. So, a lot of athletes will jump very high to make a basket. Our dancers will jump very high to make a shape in the air in a formation. And so there's, a lot of it can be, and if you think back to what they're wearing on their feet, they're not wearing a whole lot that is going to absorb the impact. Most of them are either in bare feet or, this point shoe, I've got one right here. These point shoes are just glue and they're very hard. There's no shock absorption in these guys. So when they're landing from here, they've got to have a lot of shock absorption through their ligaments and their tendons, which is a little bit different from the typical athlete. So, throughout this talk, we're going to be focusing mostly on dance medicine because that is my niche and my favorite thing to talk about. But I promise I won't talk your ear off all night, although I could. So we're going to keep in mind that while every sport and every athlete is unique, they have their own subset of different cultures, different movement patterns, different equipment, and different demands on their body. We're going to appreciate that sports medicine dance medicine is sports medicine in a foreign country. So how do we define an injury? What is an injury? Is it injured or is it just sore? Well, first we start with the chronicity of something. Is it acute or is it chronic? Now, the important thing to remember is that acute versus chronic is a designation of time, not a prognostic indicator. What does that mean? Well, acute has been around for a month or less. And so it just happened. Sometimes, acute gets stuck on with another indicator of prognosis, and so it gets a bad rap for being really, really bad. Sometimes it's just, I have an acute strain that's going to get better in 2 days. Acute just means less than a month's time. Subacute is also a cool sounding word. That's anywhere from a month to 6 months. So it tells you about how long it's been going on. And chronic also gets a bad rap. Chronic just means it's been going on for more than 6 months. But that's not necessarily, something that's going to change the whole course of your life. A lot of us have chronic things that, a chronic weakness, and what this one in your glute medius that you always have to be working on, a chronic tightness in your left hamstring that you always have to focus a little bit more on than your right hamstring. So chronic really just means that it's been going on for more than 6 months, but it doesn't necessarily mean that it's something that's ever going to hold you back. Same thing with acute. Acute just means that it's been going on for less than a month. And it's also not necessarily something that's going to hold you back. So thinking first of acute versus chronic. So let's talk about acute injuries. So there's a sprain and then there's a strain. What's the difference? Well, I've seen this mixed up quite a lot amongst all of the notes, all of the literature. I've seen this mixed up. So let's clear it up tonight. A sprain refers to a ligament. What is a ligament? A ligament is a piece of tissue that connects two bones together. So if you think about the ligaments in your ankle, if you think about one of the more famous ligaments, the ACL, anterior cruciate ligament, ligaments connect one bone to the other. And there's 3 flavors of a sprain. There's grade 1, which is an overstretch. So at the microscopic level, you'll see little tearing of the tissues. Grade 2 is a partial tear. So if you think of a ribbon partially tearing through, that's a grade 2. A grade 3 is we ripped the ribbon straight off. So that's a complete rupture. So that's where you've pulled the ligament all the way off the bone. Sometimes you can have what's called an avulsion fracture, which means you took a little chunk of bone with you when you ripped that ligament off. There's the strain, which refers to muscles. What are muscles? They are, these things that attach directly to the bone with the tendon. So you have the muscle that forms the tendon that attaches to the bone. Grade 1, same thing. It's an overstretch. So at the microscopic level, that's little bits of tearing within the muscle. That's like when you go a little too hard at the gym and you're really sore for a couple of days afterwards and it's hard to sit down. That can be a strain. Sometimes it's just delayed onset muscle soreness, but if it's really bad and you're really struggling, you might have had a grade 1 strain. Grade 2, same thing, partial tear. You've partially torn the muscle, just like a ribbon, you can partially tear that. And grade 3 is you've completely ripped the muscle, either in the mid-substance, where you're just tearing that ribbon all the way apart, or you can rip the tendon off of the bone and you can take a little chunk of bone with it, and that's called an avulsion fracture. So it's very easy to mix up sprain versus strain, but the best way to think about it, a sprain is with the ligaments, a strain is with the muscles. Let's talk a little bit briefly about ligament ruptures because they're very famous. If you watch, most of us have had some sort of ankle sprain, ACL sprains all the time. So a complete rupture, so that would be a grade 3 sprain, usually presents with a rapid onset. So it almost immediately, within an hour, you've got a lot of swelling within the joint. Effusion means swelling within the joint. And you're also going to have a lot of swelling in the tissues surrounding the joint. We call those soft tissues. And you'll often have instability of the joint. That means when you're just walking to take out the trash, all of a sudden your knee will buckle out from under you. Or if if you've ever had one of those ankle sprains where you're fine, you're pretty fine afterwards. It hurts like heck for a week or two, and then you're able to do most things, but it's always kind of nagging at you. That's often caused by instability within the joint. And then you'll also typically have a lot of laxity, so looseness of the joint compared to the other side. And sometimes you won't even feel what we call an endpoint. So if you snap a rubber band, you feel an endpoint to it. I'm doing the same thing in the clinic. I'm taking your knee and I'm pulling it to get that ligament to snap. And if I'm not feeling that, if it keeps on stretching, it usually means that there's nothing holding it back. Now, I would be remiss if I did not talk about fractures. What's a fracture? It's a broken bone. Same thing. Is it broke or is it fractured? Same thing. And so typically when we're concerned about a fracture or a broken bone, we will get x-rays. It's really important always to make sure you're getting x-ray of the joint above and below where you think the fracture is. So if you think you broke your shin bone, definitely get x-rays of the knee and of the ankle. Why? Because sometimes you can have the forces, this is a little bit of physics, but the force can transmit up through the bone and fracture much higher than where you think it is. And typically any sort of event that has enough force to break a bone, which is very difficult in a healthy bone, you're probably going to have other injuries somewhere else along the line as well from that transmitting of the force. We can't always see fractures right away, especially if it's something like a non-displaced fracture. So in these first three designations, the transverse, the linear, and the oblique, these are what we call non-displaced. So see how the bone is still in its original shape? That means it hasn't moved. So that can be really difficult to see when it first happens. So one trick we'll do, if you've ever been in the emergency room for an injury like this, and they say follow up with ortho or sports medicine within a week, that's because we're going to repeat the x-ray and see if there's any kind of healing starting around it. Later on, we're going to start looking at what that healing looks like on some real x-rays. But for now, you'll know just to repeat an x-ray in about a week. Sometimes if it's still unclear and it really makes a difference in our plan, we'll either get an MRI or a CAT scan to look further. Insurance doesn't like to cover those things, so we try not to get you a big bill. So we start with repeating x-rays, and if we really have to, we'll get advanced imaging. But there's a lot of different types of fractures, and it all has to do with the force submitted onto the bone that created that breaking point. You always want to make sure that you're keeping it still until you know what's going on. So that's splinting it either in a full cast or in a temporary cast that can be taken down in a week so that we can repeat x-rays and not have any stuff in the way. If it's displaced, that is unfortunate for you. Don't eat before going to the emergency room, because if it is displaced, you might need it to be reduced, and you're going to want to have the good medicine so it doesn't hurt so bad, but they won't do that until you've had an empty stomach. So if you're concerned, don't eat before going there. And then surgery will often take over anything that's more complex because it might require surgical intervention. So we work closely with our orthopedic colleagues. Let's go to chronic injuries. This one, most of us have had some sort of chronic injury. Again, chronic injuries last a while. They tend to come and go. They tend to kind of be more of a nag than anything else. Typically, chronic injuries, the most famous are the tendinopathy, which is a very fancy way of saying something is wrong with the tendon. That's really all it is. If the tendon's not perfect, tendinopathy. Or bursitis, which is an inflammation in the bursa. What is a bursa? A bursa is a fluid-filled sac that provides cushion to bony parts throughout the body. So you can see in this figure down here, these are all these different bursas that surround the knee, and they can all get inflamed. Typically, they're caused just by overuse. You're doing something too much. There's not enough variety within your workout pattern, or you're overusing it, doing too many, practicing one element too much. A lot of it comes down to suboptimal biomechanics. So if you remember several slides back when we talked about our motion analysis equipment, the biomechanics is everything. How you move defines how your body is working. And so if you're using, you know, what in the most positive way, suboptimal, if you're not moving as well as or healthily as you should, you're often going to develop some sort of wear and tear of a tendon or inflammation of a bursa that comes from just the increased stress that is more than that tendon is designed to take on. Sometimes it's just altered biomechanics after an acute injury. So we talk about that ankle sprain, and maybe the pain of the sprain is better in a couple of weeks, but you're always left with a little bit of irritation, crunchiness, just aggravation of that ankle frequently. And it's really coming down to, we needed to rehab the tendons and the muscles that provide that stabilization to the joint, because now we know, if say if it's either a grade 2 or a grade 3 sprain, now we've lost some of our static stabilization of that joint. So if you think about the physics of it, if you're losing some of your stabilization, you're having to hold on more whenever you're doing just daily activity. So it can get more irritated. And then there's, of course, just re-aggravating of the same old injury. So if we never fully recovered from that tendinitis, tendinopathy, it can flare up, especially if we never really addressed your biomechanics. You're more than likely, if you keep doing the same amount of the same activity and we haven't addressed your biomechanics that got you into the office in the first place, more than likely you will develop that same injury again. And so that's part of what we do in sports medicine, is trying to work on prevention of the re-injury and other injuries down the road. Bony stress injuries. So these are a really great one that I see a lot. Well, they're terrible for the patient, but they're fun for me to diagnose. So those symptoms, they're really difficult to diagnose. That's why it's fun. It's just kind of a dull ache. It typically doesn't start with anything specific. It just kind of gradually comes on. It's worse after activity or later. So either with the activity or later on at nighttime. And it's pretty gradual, pretty insidious, meaning insidious means gradual. So if we look at this X-ray here, the series of X-rays, we can see something called bony callus formation. Bony callus is like the scaffolding that goes up around a building. So if you've been to New York City in the last decade, you will see plenty of this scaffolding up everywhere. The scaffolding goes up to allow for remodeling of the facade of the building. Sometimes it's just for a safety concern based on zoning. And over time, that bony callus will develop around the bone, allowing, and it's really, really hard. So it helps support the bone and strengthen the bone. Eventually that callus will be taken down, but just like in New York City, that can be years after the injury is healed. And so that's part of the art of medicine, is figuring out, is this injury healed based on what we're seeing on the X-ray? We'll get more into this later, like right now. So what we're looking for on the X-ray, we're looking for that thickening of the bone. The periosteum is that lining of the bone. So that white part surrounding the gray. I don't think I have a mouse. Here we go. If you can see my mouse, this is the cortex of the bone. And so you can see it gets thicker right in here. So we'll see thickening, and we'll also see sclerosis, which is whitening in areas that shouldn't have whitening. And this, again, is part of the art of medicine, of learning the body. So instead of, if we were seeing thickening, whitening here, that might be, we might be able to write that off. But since it's going straight down, we say, that's something that doesn't belong. If we were to get an MRI, which a lot of times stress fractures, if you get into my office early enough, we actually won't see it on an X-ray. If you're seeing the dreaded black line, you're usually, you've waited too long. The dreaded black line is on an X-ray, but you can see it on an MRI much sooner. And so on an MRI, it's extremely sensitive and specific to bone stress fractures and stress injuries. If you look at the top part of the bone where my mouse is up here, it's dark, and that's normal bone. If you look down here, you see brightness, and that's not normal. You also see some brightness in the in the soft tissues around the bone, as well as that dreaded black line right across through. That is the fracture line, and that's lets us know that it's going to be at least 6 weeks of downtime from any kind of impact activity. So if we're seeing that dreaded black line, we have waited too long. So how do we put this into practice? Well, it's actually really quite simple. You know, sports medicine is not that hard. Where it hurts is where it's hurt. We just need to know our anatomy. Unless, of course, it's referred pain coming from somewhere else. And so it's really important to know your biomechanics as well. And that's why it takes so long to learn this. So we're going to put on our dance medicine hat and start applying some of that information to real injuries that we often see in our dancers. You'll see these in your regular athletes too. I call them regular athletes. I mean, no offense to that. Other athletes in other sports, but they just happen to be more common in dancers, and we'll see why. So where it hurts is where it's hurt, unless, of course, it's coming from somewhere else. So why do I have the anatomy of the foot and ankle sitting next to a pelvis? Well, technical deficiencies tend to run downstream. That is why foot and ankle injuries are so common in dancers, because many dancers will not put enough focus into the alignment of their lumbosacral area. And so we can see how the knees are pointing in one direction, the toes are pointing in another direction. It looks like a spiral. So that's how we end up with all these tendinitis or tendinopathies, which is the fancy way of saying there's something wrong with the tendon. It's not normal. That's why we end up with all of those in the foot and ankle. We also end up with some special injuries in the knee, one of which we will talk about. That's actually fairly common in sports medicine. And we can get a lot of hip injuries too, just from standing in an incorrect position. Biomechanics is everything. So in dancers, the most common injuries are overuse, overwhelmingly. And they're mostly coming from alignment factors. So those biomechanical issues, poor postural control, that is a sway back, which we'll talk about a little bit later in this talk towards the end. And that's also poor aerobic fitness. So if you think about, if you get winded going up the stairs, if you're going up the stairs and everything's getting kind of weaker, you're probably going to end up having a strain of some sort or a sprain. In dance, most injuries occur, most major ruptures and sprains occur in the fatigue state. That means they're either at the end of class, end of rehearsal, end of a performance series, the big season, where everything's really, where all the muscles are really fatigued. And so they're not doing their job to dynamically stabilize, and abnormal force is submitted onto the joint, onto the ligaments, and onto the bone. Most of the injuries are of the lower back and lower extremity, although a lot of my contemporary dancers and men who are lifting dancers up in the air will have a lot of upper body, particularly in the shoulders injuries, but those are less common. So let's start at the bottom and work our way up. So we're going to talk about these metatarsals. What are the metatarsals? The metatarsals are these guys right in here, right where my cursor is going. Now, can anyone spot the Easter egg lying in here? This is metatarsal stress fracture. We've got, they waited too long. They were hiding their injury. We've got the dreaded black line, and we have a lot of callus formation all around that fracture site. So it's already trying to heal, but we need to give it the chance to heal. So if you know your anatomy, you can really figure out a lot of what's going on where something hurts. So metatarsal stress injuries are one of the most commonly reported injuries in dancers, types of stress fractures, that is. They happen more often in females than males. They typically, in contemporary dancers, will happen in the 5th metatarsal. That is this guy right here, number 5. We start with the big toe and we count 1, 2, 3, 4, 5. So 5th metatarsal typically will happen down at the bottom. And think back to our biomechanics. It's happening from rolling to the outside of the ankle. So more stress is being placed on this bone, and so it develops that stress fracture. Now, ballet dancers, as you can see here, understandably get a lot of 2nd metatarsal fractures. The 2nd metatarsal, as you can see, is the longest metatarsal. And so that's picking up most of the force. And so when they're standing on their toes, they're picking up a lot of force going right up and through here. And same thing if they were standing just on what we think of their tiptoes, where they're standing on the ball of their foot, same amount of force is being brought up through that metatarsal. So that is the most common type of stress fracture, bony stress injury that we see in dancers. How do we treat it? Well, if the cause is suboptimal biomechanics and potentially fatigue, what we need to do is fix the biomechanics and increase the endurance of those muscles. So how do we do that? Well, with the stress fracture, it's one of the few injuries I can't get around. I have to take the weight off of it. We have to rest that bone for about 6 weeks, depending on how quickly you got into the office to see me. And so what we will do during that time is a lot of non-weight bearing cross training. So that includes something called Pilates. My staff makes fun of me almost every day because I recommend Pilates to just about everybody because I'm trying to put myself out of business. Floor bar, which is a special training technique where you essentially do ballet, but laying on the floor, as you see in this figure here. And then swimming. Swimming's really great because it's a full body workout. It rewards you for being bad at it because the less efficient you are getting from one end of the pool to the other, the more of a cardio workout you at least got. As long as you're not doing anything weird with your strokes, that's going to develop another stress injury. But swimming's great because sometimes you have to say, don't push off the wall. But swimming's really great because it's non-weight bearing and you can really work on strength and endurance without putting stress on the bone. I always encourage dancers to take the opportunity. We talk about opportunity injuries, and this is an opportunity injury for sure. We work on other parts of the body, so working on the upper body. Same thing if you were an athlete, a tennis player, and you injure your wrist, what else can you work on? You can work on your footwork. And so, it's really important during this time with your athletes to always stress the importance of good nutrition and rest to allow the body to really heal. And then around week 5 or 6, because everyone's starting to get antsy, we start the physical therapy. And in dancers, particularly with metatarsal stress injuries, we're working on the mechanics of the releve. Releve is to rise up onto your toe. And so that really comes from the top down. If you remember that pelvis tilted forward and everything was all twisted and out of a line, we're working on getting everything into alignment. That's really going to be the thing going through. Just like in a tennis player, you would work on their serve and their swing and keeping everything in alignment. Same thing with a jumper, same thing with a runner. Everything's all about that alignment. So that's really the key to all injury recovery. So right now we are looking at the medial. Medial is a way of saying closer to the midline of the body. So this is the midline of the body. And so medial means closer to the midline. Lateral means the other side. So if you just remember one, the other one's the other one. So medial means towards midline. So what we're looking at here are some of the tendons that we see on the inside of the ankle. In particular, we are looking at this guy right here, right in the back, called the flexor hallucis longus. Flexor hallucis longus runs, as you'll see, right next to this Achilles tendon, which means it is frequently missed and incorrectly diagnosed as Achilles tendonitis. So if something's just not getting better, sometimes you need to seek a second opinion, just get a fresh set of eyes on it, just say like, could it be something else? Are we missing anything? Because this guy right here is a secret culprit. And this one can really cause a lot of problems for dancers in particular. So we see this in conjunction with something called an os trigonum, which we'll talk about in a subsequent slide. It happens because this tendon crosses across two joints. So it's here and it comes all the way down and it attaches to the big toe, which is out of frame here. And so that means it's working 2 to 3 times harder than the other muscles as it's rising all the way up onto the toes. And so that means it puts you at risk for, overuse, because it's doing more work. It's going to more easily be overworked. And it's often coincides with something called functional hallux rigidus, which is a fancy way of saying the big toe is tight. And so you'll see in this picture here, the fuzzier one, I was figuring out how to focus my camera. This dancer, when their ankle is relaxed, they have decent flexibility in that big toe. But when you pull the foot up into a neutral position, they lose that flexibility. And so that's something that goes along with the flexor hallucis longus tendonitis. There's also the bony parts of the posterior ankle. So we have that os trigonum that we talked about. That's right here. The os trigonum is a little piece of bone that was supposed to attach to the rest of this bone here, the talus. It shows up around ages 7 to 10, and it's supposed to attach, but sometimes it doesn't attach. And so then we call it an os trigonum. If it does happen to attach and it is particularly robust, we call it a steta process. And typically we see it drops down. A normal talus will, or an average talus, I should say, these are all normal variants. An average talus will be a little bit more narrow, but if you have a big projection, if it's not attached, it's an os trigonum. If it is attached, it's a steta process. And most of us have no idea that we have one back there. However, if you like to dance all the way up on your toes, then, or if you like to kick a ball, then you might end up having inflammation in this area. So we see this MRI over here. What we see, this is normal bone, dark is normal in this type of MRI. And the bright bone here, that's inflammation within the bone. And see this white stuff here, that's fluid, that's inflammation in the surrounding soft tissues. So this can lead to ankle impingement, posterior, meaning in the back, ankle impingement. So that's inflammation in your os trigonum, that's steta process inflammation. You can just pinch those tissues really hard. Sometimes it comes after a sprain, if you sprain it really bad, or you just are really particularly flexible and you keep jamming up onto your point shoes. It's kind of like biting your lip. It gets swollen and inflamed, and so it's more easy to keep biting it because it's now right in between your teeth constantly. And so as you can see in this wonderful radiograph of a dancer all the way up on point, things really get pinched back there. If we think about what kind of space you have normally here, when you go into this position, it gets a lot tighter. So this is most common in female classical ballet dancers. So what do we do about it? Well, we got to work on the underlying biomechanics that cause this to happen. So during the treatment process, with any athlete, we're going to always avoid taking them out of their sport altogether. Because if you've ever been sick and had to not go to the gym, or you got injured and you were away from your exercise for a really long time, not only do you usually feel kind of crummy, and somehow, despite the rest, having less energy, but it gets really difficult to get back into your workout routine. The other thing too is what I often see is that if we think about the fact that most of these injuries are coming from weakness and lack of endurance in the muscles, complete rest means that we have to rebuild all of that strength on top of rebuilding the strength of the injured area. So if we allow everything to rest and relax for several weeks, we now have to rebuild all of those muscles too. So if we jump back in too much too soon, if someone says, hey, take 6 weeks off of running, and then you jump right back to running 5 miles without having built up to it, a lot of times you do that a couple of times, you end up back in the office again with a new injury. Getting back into your sport after a period of rest is a very dangerous time for the rest of your body, because you don't necessarily have that strength and endurance that you had when you did get injured, or you don't have enough for what you're about to ask your body to do. So that's where our physical therapy colleagues are invaluable to helping you get back in a safe way. Sometimes we do have to pull you out of everything for about 1 to 2 weeks. You won't lose it all if you rest for 1 to 2 weeks in a row completely. It'd be okay, but there are a lot of things that we can do to keep you active and keep you in that routine during that time, and allow you to work on other things, other parts of your body that might be a little bit weaker and not pulling their weight and causing you to get these particular injuries. When we do go back, we're going to be focusing all on the mechanics. It's all about biomechanics and avoiding suboptimal mechanics, gripping of the muscles, clenching of the muscles. We're going to be stretching muscles that are tight, strengthening muscles that are weak, and really just working on that. So we get creative. If you ever come to me for another type of injury from another sport, I may ask you to demonstrate for me in the office, so that I can come up with a way around it, so that we can keep you working while resting the affected joint. And so a lot of these are just different creative ways to be able to keep going, even if you're not able to dance all the way up on your toes. There's still a lot that we can do. Some of the dancers really continue this stuff afterwards because they find a lot of value from things like just closing your eyes while trying to balance. Moving up, we are now into the shin. If you remember earlier, we talked about that dreaded black line. If we have gotten to this point, we've waited too long. But if we're looking at these muscles of the lower leg, one thing to look at, if we think back to our posterior ankle view with all of these tendons, the tendons lead up to the muscles. The tendons are controlled by the muscles, like puppet strings. And so all those muscles live in your lower leg. So that's your calf muscles, the front of the muscles in the front of your leg where your shin is, the muscles along that medial, meaning next to the midline part of your shin. And that's a big cause of medial tibial stress syndrome. So medial tibial stress syndrome is when the muscles are pulling against the bone and causing inflammation. A tibial stress fracture is this guy. That's a big bummer. Stress fractures sometimes heal faster than medial tibial stress syndrome, though. That's like that nagging shin splint that'll come if you do too much too soon or you don't warm up right, but it doesn't actually really hold you back. It's just annoying. A stress fracture, it will get progressively worse until you treat it. So they're very common in dancers, not as common as the metatarsal stress fracture, but they come from, doing a lot of high intensity jumps. This dancer is, 5 feet in the air. She's about to land on a surface in nothing but glue and fabric, landing on the ground. Now, some stages are what we call sprung. So your practice floors in most studios across the country nowadays are sprung. So these floors have a little bit of give to them when you land, but unfortunately still it's a holdover. A lot of the stages do not have sprung floors. And so if you have a dancer who's doing a particularly long performance series, like my Broadway dancers, I would have trouble with this. Any of the Rockettes, because they're performing at Radio City, which is a steel enforced stage, they would have a lot of trouble with injuries from just being on such a hard surface. If you think of yourself, if you have to stand on concrete all day, think how bad you feel at the end of the day. A lot of dancers have poor nutrition as well, because dance is an aesthetic sport, meaning that the emphasis is on how you look. And so there's a particular physique that many dancers will cut their nutrition to try and achieve. And that's unfortunate, and that does also lead to injuries. I see that a lot in my runners too. So it's not just the dancers, but dancers do tend to spend clock a lot of hours in the dance studio. A typical class is an hour 45 to 2 hours long, and that's just one class. And a lot of dancers will take a couple in a day, especially if they're training when they're growing up, or if they're a professional, they'll take a 2-hour warm-up class and then they'll proceed to rehearse for another 6 hours, and that's a typical day. They're not jumping the whole time, but they're doing a lot. So how are we treating this one? Again, if it hurts, don't do it. So we're avoiding the things that are irritating the injury while still allowing the athlete to continue their training. We're going to take out impact. Anything that caused the injury, we should really be thinking about how to avoid it. And then we're going to get into physical therapy that's focusing on, you guessed it, mechanics. And so we're working on jump landing mechanics. This is where something called the Pilates reformer really comes into play, because you're actually horizontal, laying on part of the equipment, and you can push off the jump board and practice jumping with varying degrees of resistance. So you can build up to getting back into jumping on against gravity safely. We're also going to be working on their standing mechanics, so they're not locking back into knee hyperextension, particularly when they're on point. So if you see this dancer here beautifully demonstrating, see how her knees are bent backwards? That's hyperextension. That is a very difficult concept for me to get through to dancers, that this is technically bent. This is not straight. They will say like, well, I have to straighten my leg. This is not straight. This is bent backwards. This is straight. And you see she's much more pulled up. Her knees are rotated over her toes, and all of her muscles are engaged. It's even aesthetically speaking, it's an aesthetic sport. It looks better. It's way healthier. So let's move up to the knee. This is what we call a sunrise view, this X-ray right in here. We're looking straight down at the knee. This is the femur, and this is your kneecap, and it sits in this little groove, and it likes to surf side to side and get itself irritated. This is controlled by all these muscles attaching here into the knee. These are your quadriceps muscles. You've got some of your hamstring muscles and adductors coming in, inner thigh muscles coming in down here, and that's at the pes anserine attachment point. So you can get a nice bursitis right in there. But this is one of the most common injuries of all that I see in sports medicine, and it's a muscle imbalance. It's called patellofemoral syndrome, and it's caused by a muscle imbalance of these muscles here, causing irritation underneath this kneecap. So in dancers, this is from poor neuromuscular control, meaning they're not holding their muscles correctly. They're allowing their pelvis to sway back. They're allowing for all that rotation at the knee joint. This is from, they do a lot of deep squats. So Horton hinges here. We've got grand plie, which, you know, we're doing all the time. So a lot of deep squats that we're doing. Forcing turnout, hypermobility. That's a whole nother specialty. That's a talk for another day, but that's, you know, how dancers can kick their face. That's because their tendons tend to be a lot looser than the average person. Their muscles and their tendons are looser, so they have greater ranges of motion, which allows them to do things very easily that put the joints at risk. And a lot of dancers avoid strengthening their quads because, again, it's an aesthetic sport, and there's all these ideas that if they do anything to strengthen their quad, it'll get bulky, which is not actually true. So when we're in class, if it hurts, don't do it. So that means they hate this one, but you got to bring in the turnout, because if you look at this dancer right here, you see these mechanics. You see the tibia, the shin bone is twisted, the knee is pointing at us. The toes are pointing out there, out my window, and everything's rolled in too and superpronated. If they bend their knees and do a plie or a squat, their knee is dropping in front of that toe instead of being over at the second toe. Their knee is all the way out over here. And so you think of all that twisting at that joint, of course your kneecap is going to be rubbing along the groove and getting irritated. So what are we going to do? We're going to focus on fixing that, fix the mechanics that caused the injury. So we're strengthening the muscles up in the hip to allow the knee to be rotated, the thigh to be rotated to keep up with the knee. We're going to be strengthening the hamstrings. Dancers have very flexible hamstrings, but they're not very particularly strong. And we're working on controlling that turnout so that when you land from a jump, if you've ever watched a figure skater in the Olympics, the slow-mo of them landing on that blade and their knees, all the way crossed over midline, it makes me cringe. We're working on the control of making sure that knee stays over the toe when you hit the ground. Cross training is really great for supplementing anything that you're doing in physical therapy and also continuing those lessons long term, because physical therapy should just be a temporary thing that you do to get better and learn what you need to learn to be preventative so that you don't get another injury or a repeat injury. But after that, you want to be incorporating those lessons into a daily fitness life. It's not just like you go and then you're perfect. The work continues. And then going all the way up to the hip now, one of my favorite things, I see it all the time, are these issues with these muscles in here, these deep muscles, the iliopsoas, and then the psoas meeting the iliacus and creating the iliopsoas tendon. These are deep muscles. You can see that's inside the pelvis that it's crossing across there, a very deep muscle. Sometimes it's really hard to poke with your finger. Most of the time, you're going to get these superficial muscles like your glute maximus and your tensor fascia lata, which make up the IT band running down here. So if you ever wonder why when you go to the doc for knee pain and they send you to BT and all you're doing are glute exercises, well, that's why, because these guys make up the muscles and the fibers that come down and control your knee. It's all connected. So we see a lot in dancers snapping hip. And when I used to lecture in a lecture hall before COVID hit, I used to demonstrate snapping hip for you guys. It's where, a dancer, like your hip just pops and it's sometimes painful, usually not. There are two brands or two flavors. There's internal, which is your iliopsoas snapping over itself. And then you have your external, which is your IT band and your glute maximus. Whoops. I am giving away the secrets. It's your glute maximus snapping over your greater trochanter, this bony prominence right here. In general, clicking and clacking within your body is just soft tissues moving over each other or bony prominences. It's not something like loose floating around in there most of the time. But it does tell you that there is some sort of muscle imbalance happening that we need to work on if we want to prevent injury down the road. So one of the most common things that we see in dancers is pain in the front of their hip. Anterior means front. If posterior means back, anterior means front. This often goes along with snapping hip because snapping hip is often caused by a muscle imbalance in these guys, the core and the deep hip flexors versus the quads, which can also bring your knee up in front of you or up to the side. We call them hip flexors. And it's very common. It comes from constantly lifting your leg in the air, kicking your face. And it comes from being in that turnout position because you also can grip in the front of your hip if you're not using the rotators in the back of your hip enough. How do we fix it? Well, if it hurts, don't do it. In class and training, we're going to avoid the things that hurt so we can keep working on everything else so that we don't get too far off. Our physical therapy is going to be focusing on super boring things called pelvic clocks to start with to help build that neuromuscular, nerves, brain, muscular, muscles connection, neuromuscular connection, so that if you've ever tried to, if you're someone who can't wiggle your big toe, if you've ever tried and it's really hard, and then eventually you work on it because you're like, this is ridiculous that I can't wiggle my big toe. That's a neuromuscular connection that you're building right in there. And that takes time, more time than anyone's willing to spend. And it's very boring to work on. But we got to work on it because that's how we have to be able to use these muscles correctly. If we're ever going to strengthen them, we also want to be stretching them correctly, and helping, because some of the snapping is coming from the psoas muscle itself is just very tight. And then we're retraining dancers to use the correct muscles when they're kicking their faces. And then we're coming up towards the end. Bear with me, guys. We've got a couple more minutes. So again, anatomy. And if you think this is a crazy amount of anatomy, that's why it takes so long to get through this. You're right. But there's also most of these drawings are actually from an atlas called Netter's Atlas of Anatomy. Really beautiful pictures, peels everything back layer by layer. And so it's something that if you're really, really interested in anatomy and you're like, I don't need to go and dedicate my life and go to medical school for this, but I just want to know what's going on so that when I say it hurts, I know where it actually hurts. I think that's great. I think that anatomy should be something that we all have a little bit more familiarity with. Because if you take a look at your spine right here, you'll see that we have our bones. And if you come to me, typically we always get x-rays to look at the bones. There's a couple reasons for that. But what moves the bones? About several layers of muscle. So these are just a couple of layers of the muscles that attach to the spine and control the spine. So we have the muscles that are all the way down in between the bones, these little tiny muscles. We have the muscles right on top of that are running all the way up and down the back. And then we have some deeper muscles. We have core muscles that are attaching into here. We have big muscles of the spine. And then if we come all the way over, another couple of layers up, we start seeing all of these muscles that are controlling the spine. That's a lot of muscle. That's a lot of room for injury right in there. And so that's why it's so important to always make sure you're working on your mechanics and treating the muscles too, and not getting too caught up in what you can see on a specific keyhole view. X-rays and MRIs are keyhole views of the spine. They can only look at this right over here, the bones and what's in between the bones. They can't see all of these layers and upon layers of muscle. We don't really have good imaging modality for that other than me watching you move. That's really, me and a physical therapist watching you move is one of our best imaging modalities for what's going on with these muscles. You can use ultrasound if you can get far enough down with your probe, but there are limitations with that too. So the muscles of the back are super important because when you go to do things like this, it really matters that you're supporting your spine when you're folding yourself in half and jumping. So lumbar spine injuries are also very common in dancers, and they come in all sorts of shapes and sizes, from a muscle strain. Strains are muscles, sprains are ligaments. Radiculopathy, which is a ridiculous way of saying that you have pain that's running all the way down your leg because you pinched a nerve in the spine area. You can pinch it with a herniated disc, you can pinch it with arthritis, you can pinch it with your muscles that are right next to it. Your nerve is traversing through layers upon layers of muscle, and so you can pinch it at that level too. Dysfunction in your pelvis, the sacroiliac joint, and also stress fractures in your spine. Spondylolysis is a stress fracture right here. Typically is coming down to technique errors. So if we think about suboptimal biomechanics, it's weakness and poor alignment. So if we look at this guy here, it's also just from overuse, repetitive folding yourself in half with force. It takes a lot of force to achieve this position. Repetitive heavy lifting. A male dancer in a typical pas de deux, where dance of two, will lift a woman who ranges anywhere in weight from 100 to 140 pounds. and she's moving overhead and he's moving, walking her around the stage, and oftentimes he'll flip her and as a drop down and catch her. And so there's a lot of movement that's happening, a lot of heavy overhead lifting. That's why men tend to get shoulder injuries too. But when you're learning, as this guy right here, you're still developing your technique, and probably things can go wrong when you're learning lifts like this. So the female dancer is probably like praying right now that she doesn't get injured and dropped. This guy can't quite get her over her head and is really flexing through that lumbar spine. So that's a lot of pressure going down on the bones. So when you see what the movement of how the injury happened, you can understand why it happened, and then you can understand, one, how to fix it, and two, how to prevent it from happening again. So that's why it's so important to make sure that you're always thinking about the mechanics and how things are happening and how things are moving. That's why you see a lot of us on the sidelines where the injury happens, because if we're, good with our eagle eyes, we can catch the injury or at least look at the replay and see, oh, okay, this is likely what happened. And then you have a good idea of where to go with your treatment. So if it hurts, don't do it. It's really what it comes down to, but don't stop everything. And if everything hurts, you really should get yourself into a sports doc so that you can get a better idea of how to stay active while you're recovering. Active recovery is huge. It's a recent concept in the last decade. So in dancers, they're going to avoid kicking the back of their head. So everything's going to stay on the ground, not lifting their leg. They're going to avoid bending backwards. And then in physical therapy, we are going to focus on the control of the pelvis. Now, this is all of these have been opportunity injuries, because if you've noticed a theme that every single injury is working on this part of the body right here. It's a toe, we're working on the pelvis. It's an ankle, working on the pelvis. It's a knee, working on the pelvis. It's the hip, working on the pelvis. It's the back, working on the pelvis. Why? Because it all starts here. And so when you have that correct alignment, then everything starts falling into place. So we're working on controlling the alignment in our pelvic lumbosacral area, lumbar spine, sacrum of the spine. We're working on control of that area, correcting technical deficiencies. Cross-training with things like Pilates is actually really helpful because it helps build that technique in a functional way. So you're not just holding it there, but you're learning how to use it as you're moving and stay in those correct positions as you're moving. And so Pilates is a really useful cross-training tool in dance medicine. It's also why I'm trying to get everybody into Pilates. You don't have to pay for it. There's a lot of online resources, but it's a really good movement practice for maintaining core stability and control in a functional way. So we're just working on biomechanics. So that was a lot that I just threw at you. If there's anything that I want you to take away, is that sports medicine is really very simple. Where it hurts is where it's hurt, unless it's coming from somewhere else. So know your anatomy and know your physics too, know your biomechanics. Look at what's going on, because that's how you're going to figure out what exactly happened to cause the injury. That's how you're going to know how to treat it effectively and prevent other injuries or that same injury from happening again. Every injury is an opportunity. And we tried, to keep you active throughout the whole thing. If anyone's curious, those are all my references, but I think we still have plenty of time. I didn't go too far over. I showed so much self-control,
Well, we have a lot of questions.
Shall I stop sharing my screen? You probably shall.
Yes, please do. Yeah.
There we go. Okay.
All right. Okay. Let's start with, this is a simple question, but one, you appreciate that a lot of the people who are attending as students in this are in middle, junior, high school, undergraduate. And the person asks, how did you get from dancer to doctor?
That's a great question. I love that question. I'm still dancing, which is why I have a point shoe here. I'm sewing this right now for wearing it tomorrow. So when I was growing up, I had a lot of injuries because I was your poster child for poor alignment and overuse. And it was throughout my career that I actually learned how to dance healthfully. So I had planned to go into professional dancing. That was my thing. Growing up, I was like, I'm going to be a professional dancer. That's all I care about. My parents were like, great, that's fun. If you want to dance, you have to have straight A's or else you don't get to dance. So I always maintained good grades. I ended up going to Westchester University because in my senior year, I had put all of my eggs into getting into Juilliard's college program. Now that sounds a little crazy at first because you're like, well, that's 12 dancers out of the world a year. And it is actually crazy that I did that, but you know, youth. I actually had danced in the Juilliard summer programs, the high school summer intensives growing up. And so I was like, oh, well, you know, I have a good chance of getting in. And my parents were like, well, if you don't get into Juilliard, obviously you're not good enough to actually make it anywhere. So then you have to go to college. Well, when the reality ball hit and I didn't actually get into Juilliard, it was fairly late in the year. And anybody who's going through the college process right now or has known someone who goes through the college process, late in the year is not the time to be figuring out your plan B. And so I ended up I had gotten into a couple of schools that I had applied to just because, but I never actually wanted to go to. And so I said, crap, what am I going to do? Well, the school that I was growing up at actually was starting a college program with Westchester University. So I applied as a commuter student, got in within a week. And so then I started there. I was in my freshman bio class when, you know, I was thinking like, what am I going to do with my life? And it suddenly occurred to me like a light bulb went off. I'm going to be a doctor. It was just as simple as that. It was actually, you know, it was just like a light bulb went off, a light bulb moment. Like, I'm going to be a doctor. It's like, oh, I should probably change my major from environmental science. So I walked down, brand new, newly minted college freshman, walked down to the professors and said, hi, I'm Elizabeth and I am going to be a doctor. And he said, great. Walk down to the hall to the pre-med office and get yourself signed up. You're going to need to change your major. And so, you know, I went through that whole process. And so I was able, it was actually a really wonderful thing, you know, because there's a lot of ways to skin a cat, so they say. And so I ended up being able to dance professionally in college. So the college program, I completed the college program, but the company I was dancing with actually launched a professional division during my time in college. So by sophomore year, I was able to achieve the dream of becoming a professional dancer. I actually had more opportunities to do cooler roles because, you know, being at a regional company, I was a bigger fish in a smaller pond. So I was able to do a lot of really meaningful things. And I got my degree that got me into medical school. Westchester is a great pre-med program. And so I was able to get in and it's not a fairy tale story. I got in off the skin of my teeth because it's extremely competitive to get into medical school. Everybody and their brother has perfect scores and 500 extracurriculars that makes them special and unique. And so it was a lot of help from my pre-med faculty who were making phone calls on my behalf to places where I had applied. And, you know, after graduation, like a week after I graduated from college, I actually got the call that I was accepted into medical school. So sitting in graduation was a very nail-biting experience because you're like, well, what am I doing with my life? I had to actually get, unlike, you know, the first time around, I did actually have to tee up a job so that I wasn't floundering after school. But luckily I was able to not go into that and packed my bags and moved to Hershey, Pennsylvania to start at Penn State within a month's time. There are some of my classmates were called on June 30th and they had to present July 1st. And they moved across the country within 24 hours. Most of it was like they just bought a very expensive plane ticket, showed up, and the rest happened after that. So yeah, it's, you know, that's one of those things of like, it was it's a lot of setbacks that got me to where I am now. And that's okay. You know, a lot of times growing up, we think of like, oh, there's one way of doing things and that's the way to do it. But you can actually really, once you start opening up and looking around you, you can really start thinking about like, oh, wow, there are more meaningful experiences that we can have if we just look at it from a different angle. And, you know, that's a lot of what I bring to my medicine practice is like, okay, I keep looking at it from this angle. What if I look at it from this angle? What if we watch you do that step from the back or from up top? What can we see that we couldn't see before by changing our position? And the other thing too is I know it's cliche, don't give up. You're going to get far more rejection than you ever get acceptance. And so, you know, that's something to really just be prepared for, is that you will be rejected 99% more than you are accepted, but it doesn't matter because you only need one acceptance. I got one acceptance. That's what I got. Here I am. And so I went to medical school. I thought I was going to be an orthopedic surgeon. I got some really good advice to say, don't be a surgeon. So I took it. That's my one strength. I take advice. And then I discovered primary care sports medicine, and the rest is history from there. So I did a lot of work, and I was able to get into the fellowship at NYU, which is where I got to start working at Harkness. And then, you know, got to be an attending. It was a dream, working backstage with all of these dancers. And I knew eventually I wanted to be able to bring this knowledge back down to the area and start building on it for the dancers and all the performance athletes down here. So it's been, you know, at least, oh gosh, it's been at least 15 years in the making since I graduated from college that we've been working on this, and we're only a couple steps in, but you know, it's a lifelong commitment. And so that's the other thing too, is like in youth, a lot of people expect results out of you. They want you to do it right away. But that's just not realistic. Everything good takes time, and it takes a lot of rejection, and it takes a lot of perseverance and working through and stopping and looking at it from another angle. If it keeps not working, try looking at it from another angle, and keep thinking about it, keep mulling it over.
All righty, let's rapid fire through some questions here because we have a lot.
Oh boy. Okay.
Oh brother, where to start? How long would a broken ankle take to recover in general?
In general, 6 weeks.
Okay.
But then there's the PT afterwards. So that's how long the fracture heals.
Okay. What's the longest recovery time for a typical sprain?
That depends on how soon you get into physical therapy. So in medicine, we always say it depends. It's actually an inside joke. If you start with it depends, then usually your attending will be like, oh, okay, they clearly have some knowledge, and really you just have no idea. But it depends. And it depends on a lot of things. I know this is supposed to be rapid fire. If you let it sit and wait and develop poor mechanics over time, then you have to undo those poor mechanics, rebuild those mechanics, and then build upon the correct mechanics. So if you get in right away, you know, I can get a dancer, if I see them sprain their ankle and I call up my colleagues and I get them into PT the next day, as long as it's a mild sprain, I have them performing by Friday. That's if the sprain happened on a Sunday, they're on stage by Wednesday, they're performing by Friday. If you let it go, it could take a while. It could take several months of work.
Okay. Is tennis elbow a tendinopathy? Is there a prevention remedy for tennis elbow?
That's a great question. Yes, it is a tendinopathy. Very good use of that term. Proud of you. And it is caused by poor mechanics and overuse. So how do we prevent it? We make sure that the muscles at our core, so our shoulders, our back, upper back, they're all optimized in their mechanics. I see a lot of tendinopathies of the elbow that are coming from weakness in the shoulder. So things, you know, you're carrying things with your elbows up because you're not really using your shoulders. And so all that force is transmitted down onto your poor little tendons in your elbow. And if you don't fix that, no matter how expensive of treatment you put towards your elbow, it won't get better. So you have to look at the mechanics of what's happening upstream. In general, if you always start by looking what's upstream, you're going to see some things that might be causing that injury down there. Sometimes it's truly from just doing a lot of this motion. Sometimes I'll see epicondylitis or tennis elbow that happens from building furniture, especially my college kids, building furniture for their apartments and dorms. When you're just doing this motion a lot, you can get it simply from the overuse, and it has nothing to do with your shoulders.
IKEA syndrome.
IKEA syndrome, yes.
Right. Can costochondritis heal without taking any anti-inflammatory medications?
Yes. It takes a long time no matter what you do because you're constantly using that. You can't really rest your ribs. You can avoid the things like if you got it from, partnering where you're constantly putting pressure on that area, or you were like pushing yourself really, really hard in cardio and you're you can rest that aspect of it, and where you're just kind of walking around or doing light cardio. So as long as you're resting it, it helps calm it down. The anti-inflammatory just tries to speed the process along, but I've had elite athletes who I've thrown every anti-inflammatory out in the book at them, and it still takes a long time to heal. It's just a bummer.
How long does a stress fracture take to heal, and how would you treat it?
It depends. I'm sick. So typically 6 weeks. Bones takes typically 6 weeks to heal, but again, we have to rebuild. So we have to correct mechanics. And if I had to completely rest you, depending on how complete the rest was, I have to rebuild from there. And then I have to train you to have correct mechanics. And then I have to, build your endurance from there. So oftentimes, realistically speaking, we might be having you participating in things, but we won't have you better, because I don't want you just back. I want you better. That can often take 3 months easily, sometimes longer, because of what we have to build upon, healing the fracture, healing the bone itself, and then building upon those mechanics so that you can actually handle the load so that things don't get re-injured again.
Right. So I'm going to ask a series of questions about the foot, ankle, and whatnot, but I'm going to lead off by asking, how often do you collaborate with podiatrists or physical therapists or other colleagues in closely aligned disciplines?
Oh, all the time. The more you can collaborate, the more the patient wins, because medicine is just like in dance, we dance amongst a core, we dance with a lot of different people. Same thing in medicine. Medicine is an art, and art wins when we collaborate. So I collaborate as much as possible. I was just talking with a physical therapy colleague today, asking like, hey, are you familiar? How comfortable are you with treating ileoPsoas syndrome? And they said, not very. I can find someone who is. And my answer was, no, let's fix that. I'm going to come in and we're going to learn how to treat ileoPsoas together. And it's going to be great. And so just being very open and collaborative and collegiate is really the best way to approach any kind of injury or any aspect of any specialty in medicine. Really, it should be multidisciplinary and collaborative.
All right, here we go. On the foot.
All
Are
right.
the foot injuries that cause pain but are not diagnosed by X-ray or MRI, how do you diagnose these?
That's a great question. Sometimes I'll use ultrasound, but most of the time I will watch you move. Sometimes I will watch you move and video it and put it in slow-mo, which my dancers hate. But it's a really great way of seeing what's going on, because a lot of times it's not so much an acute inflammation, acute meaning very brief period of time. It's actually just pain sensory fibers that have been set up from the poor mechanics that have developed or caused the symptoms in the first place.
All righty. What is the reason for chronic pain in the back of your ankle?
Well, it depends.
It depends.
There's a lot of things in the back of your ankle, and that's why So you can have, it could be a tendinopathy, it could be you're pinching the soft tissues because there's a bursa that lives back in there too. You could have an osteotrigonum that's getting pinched constantly and it's just irritable. Sometimes it's more of a warning shot that you're feeling back there of you're either going further than your ankle is comfortable with, or you're gripping something in the back in order to be able to achieve that position. And so you're getting pain back in there, or you're overworking those muscles because you're not using enough muscles further up the chain.
Yeah, I'm old enough to remember when clogs were very, very popular
Oh, yeah.
shoes to wear. Of course, they provide no ankle support. They were heavy, and I was constantly having pain in my ankle just because of how I had to hold my foot to
Yes.
keep the clog on my. I mean, they were backless clogs
Oh, yeah.
were a weird thing. Anyway, can you please comment more about the metatarsal injuries, especially Freiberg's disease?
Oh, Freiberg's impaction. That's a good call out. Freiberg's impaction is actually an AVN, avascular necrosis of the head of the second metatarsal. So it's a little bit different from a stress fracture. Stress fractures in the metatarsals are, again, they're coming from, there's an increased amount of force, an abnormally increased amount of force hitting a certain spot on the bone. And so what happens is you start with some inflammation in that spot, and then over time that bone is the metabolism at that area is not able to keep up with the forces on it, and so you start to develop a fault line going through the bone, and that's that fracture line that develops over time.
Okay, this question was from the very beginning, and it's a little bit out of context for me now, but something about the Swank Memory Center and the Safe Steps program. Are you?
Oh, yes, I run the Safe Steps program right now.
Oh, well, do tell us.
That's really more of necessity. One of my colleagues, I said to her, I was like, it probably seems very ironic that the dance medicine doctor is currently working with osteoporosis and fall prevention. And she goes, you're just helping people move gracefully throughout their lives. And I was like, that's a really good way to spin it. So it was actually part of necessity. It turns out that I do have a lot of, because I watch people move for a living, that's what I do in Safe Steps is I watch you move. I watch these people move and I look for possible biomechanical issues as to why they're falling. Sometimes it's coming from something medical. That's why it's a joint program. So you will see both me and a geriatrician during that visit. And so I'll be watching you move. I'll be evaluating how you move. And then the geriatrician is going to be doing a full medical history, looking at all your medications, looking for any kind of neurological disorders that could be causing you to fall as well. It's currently housed in the Swank Memory Center, which ironically is really difficult to get to for our poor patients. They have to walk like a mile to get to our office. But we're working on that. But yeah, that was one of those things that they needed someone to help, and I actually had the skills, the transferable skills to help with it. So that's how I'm doing that right now. But yeah, that's why. You see that.
All right, a couple of ganglion questions.
Ooh, ganglions.
All righty, let's see. How do I want to put these together? All right, well, let's start simple. So, what's a wrist ganglion? And the context here is somebody who's a tennis player. And so what is it, and how do you get rid of them naturally? And then another question was about using a heavy book or a Bible to break a wrist ganglion, and is that recommended?
I was just about to joke about that. Yeah.
Take it from there.
Well, the joke is you take this, you take Gray's Anatomy, which is this massive, massive tome, and you open it up to page, I don't know, you just make up a number, 762. You open it up and you get people involved and they're like really invested in the story. You open it up and you place your hand on it and you close your eyes and you whack and you smack it. And you try to rupture the cyst. And that's a really great way of rupturing ligaments and other things in your wrist. I don't recommend doing that. Don't use a point shoe, don't use a Bible, don't use anything to try and rupture these things. They will go away on their own. Sometimes people will try to drain them. I don't, because they often come right back. Why? Because what is a ganglion? Let's talk about that for a moment. So a ganglion, well, let's be specific with our terminology, because a ganglion is a bundle of nerves. A ganglion cyst is an outpouching of the joint. So a joint is naturally filled with some fluid, and a ganglion cyst is a small outpouching of that. That's why it doesn't really do much good to suck the fluid out of it, because it'll fill right back up again. Sometimes if it's really bad and it's really getting in the way, a surgeon will go in and remove it, but they really try to talk you out of that because it often comes right back. So what we need to do is look at, why is that joint getting inflamed and getting extra fluid in it? Because joints have a normal amount of fluid, but when a joint is irritated, even if it's not like a really angry inflammation, even if it's just irritated, it'll fill up a little bit. And then that can pouch out. So you want to look at how you're using your wrist. And this comes down to maybe videoing your swing. If you're a tennis player, looking at your grip, but then also videoing your swing and playing it back in slow-mo and seeing, is there extra movement happening? Movement creates friction. Friction creates more fluid, sometimes also inflammatory fluid, which is really painful. But any kind of extra movement can sometimes create more fluid at a certain joint. So that's the same thing with the Baker cyst in the knee. That's the same thing. It's just an outpouching of the knee. And that's why I usually try to talk patients out of having them drained. I don't actually drain them myself because it's actually a dangerous procedure. So I usually say, don't do it. Let me treat the problem that's going on inside your knee. And so that's what a ganglion cyst is. It's just an outpouching of the joint. Sometimes it's really inflammatory fluid that's in there. Sometimes it's just an increased amount of fluid after a lot of friction.
All right. Speaking of fluids, what is it called when there aren't enough fluids around the joints, and how is that rectified?
Interesting. That would probably be more along the lines of an arthritis condition, where the joint is getting more degraded over time, and the fluid that's in there is more inflammatory and it's attacking the cartilage and the bone. Arthritis is one of those chronic, so long-term, more than 6-month conditions that have episodic episodes or short periods of flare-ups that are acute. So they'll typically last about 30 days, where all of a sudden you have like normal aches and pains and all of a sudden your knee blows up. That's inflammatory type of fluid. So probably arthritis would be the main one that you would think of. And it's not so much a lack of fluid, it's really more of a lack of the cartilage between the joints.
All righty. And since we're speaking about arthritis and inflammation, I'm going to give you two questions at one time.
It's probably for the best. I keep going on.
Could any of the ligaments, tendons, or issues with dance medicine or sports medicine be mistaken for any kind of osteomyelitis? And do you see similar injuries with autoimmune diseases such as rheumatoid arthritis within patients?
That's actually an outstanding question. So one of my residents who I'm mentoring actually just presented one of my cases, which was a patient who came in with ankle pain after a sprain, but something didn't look right. And I ended up working it up, and it turned out to be an infection. It was an osteomyelitis, an infection in the bone. I had a pediatric case in New York that happened to, where the symptoms didn't really match up with the timeline, and something was off. We got x-rays, something was off about the x-ray. In New York, I had my radiologist like on my Rolodex, so I could just call them up and say, does this right to you? And they said, no, it doesn't. And so we decided to get an MRI, and then, had to rapidly coordinate care to get the kid into the OR right away. But yeah, it often, when you have patients coming to you, you have to have really good spiny senses of Even if you can't nail the diagnosis yourself, you have to be able to recognize if it's your specialty, and if it's not your specialty, whose is it, and be able to refer in the correct way, so that you can really seamlessly transfer care over. So I get a lot of that in sports medicine, because you think, oh, it's an injury, let me go see the sports doc. But really what it is actually an inflammatory arthritis. So it might look like our regular old osteoarthritis, wearing down of the sole of your shoe. But really it's inflammatory. And so when we go to drain the fluid, or I might ask you some random questions, be like, any rashes lately? Like, what does this rash have to do with my swollen knee? And then I'll ask, any ulcers, any stomach problems? And so, if I'm asking random questions, what I'm doing is actually a rheumatologic screening, because a lot of times patients will present to me with what they think is just like, oh, it's an orthopedic problem, it's a joint. But really it's an overall inflammatory process that we have to be able to pick up on. And it's the way we pick up on it is, this is where the art of medicine comes in. It's not a particularly exact science. You use your spidey sense. If it doesn't sound quite right, it might not be. And don't just, what we call premature closure, don't just say, well, it's patellofemoral syndrome, that's what it is. Might be Lyme disease. And so you have to keep thinking, keep an open book or an open mind, bring the patient back. And if things aren't getting better, ask yourself why. What else could it be? What else could be going on? And don't just think biomechanically, think also physiologically, what else can be going on within the body to affect that joint.
All righty. I've been trying to group these, but they're getting a little bit more random. All right, let's go to the pinched nerve category. So again, I'll ask you a couple at once. We hear about pinched nerves in the spine. Are there nerves that could get pinched in the knee? Is the first question.
Yes.
Does the sciatic nerve affect or have any connection to foot injury? That's the next question. And oh, this is going to be, it depends. Is there any easy way to differentiate between pain in your hip and pain in your lower back?
Yeah. So the answer to all three of those is yes, but because we're here in mini med school, I'll elaborate. You can pinch nerves anywhere that there's a nerve, you can pinch it. So that means even in the knee, there's several nerves that run along the knee, and you can pinch a nerve at any point there. The sciatic nerve is a really interesting question, because you can cause irritation to the sciatic nerve from a foot injury, changing the mechanics of your entire kinetic chain going up the leg and causing more tightness in your hips, because your sciatic nerve is coming out in the posterior, meaning back of your hip where your buttocks is. So you can get tightness coming from there from a foot injury, either on the same side or the other side. This is why I hate walking boots, just as an aside, because they cause all sorts of problems up in the lumbosacral area. The lumbosacral area, so the pelvis, is an extraordinary complex area. It is not easy to differentiate. There are a lot of exam maneuvers that we will try to use to be able to figure out where something's coming from. We might do MRIs to rule out certain things with our keyhole views, to be able to say, okay, it's not the bone, it's not the joint, it's not this tendon. We did an ultrasound, it's not that tendon, it's not this ligament. Okay, so that means it's probably the muscle. Let's watch them move. And sometimes what we'll have to do is we have to start with mucking around in there a little bit with physical therapy, starting with different types of stretching, different types of strengthening, because things will unveil just like an onion, you start pulling back the layers. You fix one thing and then you start seeing, oh, actually this is coming from over here, or they don't have enough motion in their thoracic spine. And so lumbosacral, any kind of pelvis injury can sometimes take a while. Like we might do an extensive evaluation in the beginning, but it might take some time with a physical therapist to really tease out what exactly is the root cause of all the symptoms. Sometimes it's multiple things. Usually it's layers upon layers of something going on.
All righty. Sorry.
No, it's okay.
So many questions. Okay, let's talk about biomechanics for a minute. From the biomechanics perspective, are people with naturally bowed legs more susceptible to soft tissue injuries and or arthritis in the knees and other lower body joints? If so, is there anything that can be done to help people who are bow-legged?
The way you're shaped is going to be natural you. So all of your tendons are all, developed around your bones. It depends on how your bones, if your bones are if your legs are bowed because they're rotated in and you have a lot of that hyperextension, that's going to be one thing. It'll be different if just your tibia and your fibula are bowed out, versus, your femur being bowed. But it does change your mechanics. And so it can predispose you, depending on what activity you choose to do, it can predispose you to certain knee injuries and overuse injuries, just because your mechanics are going to be a little bit different. We see this a lot in dancers who are all trying to achieve the same look and the same line, but their bodies are very, very different. The way you prevent those injuries is working with the body that you have and being really mindful of your alignment, making sure your knees are always over your toes, particularly the second and third toe. In whatever you're doing. If you're doing straight ahead running, when you land, your knee should be over your toe. If you're, jumping, doing a triple axel and landing on a blade, your knee should be over your second and third toe. If you're, doing pointe turns, when you plie, knee should be over that second toe. No matter what position you're in, keeping that alignment and keeping a really good control over your deep core muscles. This is for anyone. If you're just lifting up a laundry basket, having good mechanics when you're moving is going to really help prevent those injuries. And also just working with the body that you have, understanding your body and understanding that you're different from the person standing next to you, most likely. And so you're going to need to work a little bit differently from them. So a lot of the training, the standardized training regimens don't always work for everybody. So being careful and diligent to always do what you need to do to prepare for that training regimen, but always focusing on alignment.
All righty. Speaking of one person being different from another, and with our aging population, do people with spinal compromise, and in this instance, the person says 6 inches of height loss or more, have options for strengthening / improving through sports medicine?
Yes. So probably if you're shrinking that much, you probably are working with someone for osteoporosis. And if not, you should at least be evaluated for that, because that's the most common cause of that shrinking. That much shrinking, that's pretty extreme. We start getting excited when you lose 1 inch. But there's a lot of ways to be able to strengthen your core without bending your spine, because the big thing that you're going to avoid if you have osteoporosis is spine flexion. So bending forward, things like sit-ups, we want to avoid. But the plank is your best friend. Everybody loves the plank. I don't know why everyone hates it, but the plank is a really good one because you can build that core stability, that strength. There's a lot of variations to the plank in order to make it dynamic. You can do it on stability balls, working with someone, Bosu balls, to give you a little bit of wobble and instability to really test your core, but you can really get a lot out of your core without ever bending it, and it can really serve you long term.
Okay, hold on. I'm just was side answering a question. Lots of people saying thank you. People who have been leaving, saying thank you and how wonderful it was. Okay, I'm not even sure whether I can pronounce this. Can a vascular necrosis in the femoral head be effectively treated without surgical intervention?
It depends. Depends on how bad it is. So AVN of the femoral hip is an easier way of saying avascular necrosis. It depends on how bad it is and how early you catch it. Sometimes, especially if you're younger, you can heal it by being on crutches for a really long time, non-weight bearing on that joint. It usually takes a couple of months, several months often. to let that bone heal and rebuild. We're usually going to be treating you, depending on what caused it, we're going to be treating you with some sort of bone builder to try and help you out. It's a hip, so it's going to be really hard to treat it with a bone stimulator because that's very surface level. But it is possible, depending on if you caught it really early. It is possible, especially if you're younger. If you're older, unfortunately, age is a little cruel in that sense. It gives you a lot of wisdom, but you have to now use that wisdom. That's the only thing, is that life expects you to use what you learn. And so the older you are and the worse it is, the chances of being able to heal on its own start to go down. And so if we catch it really early, there's a lot of hope. There's a lot of aja, no matter what, that's in store for you. But there's still ways. But if it's not healing, it really is, then we have the conversation of how much is it affecting you. And if it's really getting in the way of you being able to move, then we talk about finding you a surgeon who you feel comfortable with, because that's important too.
I'm going to combine two questions again, and hopefully I capture the intent of what both people are asking. So a patient presents with an injury and a treatment plan is formulated. However, the outcome isn't what the patient or the provider was hoping for. At what point do you, in essence, call it and say, okay, you actually have moved from an acute injury to a chronic fill in the blank? Is there I'm going to guess it depends is quite literally part of it, but at what point do you say we're going to shift gears on how we're approaching this?
Yeah, I think it's always wise to constantly be asking at every checkup if we need to switch gears. Is what we're doing working? And we start asking that from the very beginning. And so that's why we keep you with close follow-up with someone like a physical therapist who you're going to see multiple times a week. We're in usually constant communication. A lot of stuff happens behind the scenes too that we don't always tell you about. So if something's not going well in a treatment process, a lot of times we'll collaborate with our colleagues, say, hey, I've got 32-year-olds, the shin is just not getting better. This is what's going on. They're a horseback rider. Any thoughts on what to do? This is what we've tried so far. I do a lot of those curbsides for my colleagues across the country for dance medicine. They'll call in and be like, they've got this weird thigh pain. And I say, well, you've ruled out a femoral stress fracture, right? And they say, yes. They say, all right, well, send me a video. Let's watch her dance. And so we'll sit there and we'll look at it and say, like, okay, well, let's try this instead. And so a lot of times there's a lot of collaboration happening behind the scenes. That's what should be happening, is a lot of collaboration behind the scenes and a constant communication of, is what we're doing working? Sometimes we have to give it time in order to decide if it's working or not working, which can always be tough for everybody to wait and see. Nobody likes to have to wait. But we always try and keep that open mind. Sometimes if we've tried everything, if I've exhausted I've used every tool in the book, I've talked to all of my colleagues and I really can't quite get it, I'll refer you on and I'll say, hey, I can't answer this, but this person might be able to. I've already given them the scoop and we send you over. Sometimes we've exhausted everything and it turns out to be a surgical case. But what I always say to people who are on the cusp of surgery is you want to do everything you can, because rolling into the OR is a very intimidating experience. I've been rolled into the OR and I've stayed as a trainee. I was a resident and fellow. I was able to accompany my patients into the OR because I was going to assist their surgery. And it's an intimidating thing to go in. So you always want to make sure you've done everything. So when you're lying there on the gurney, you're like, I did try it all, didn't I? I really do have to do this. Yes, I do. Okay. Hopefully it goes well.
Right. Okay, so we've got about 12 minutes left, and we have 22 questions.
Good Lord, I don't know if we're gonna make it through all of them. I'm
So
so sorry,
I
guys.
don't think we are, and so I'm going to say to people right now, I'm sorry if we don't get to your question. So you have been prolific in question asking. Okay, will L5 injury heal after surgery?
It depends. If you're treating the entire spine, yes, but that includes getting with a really good physical therapist to work on the muscles. Muscles move bones. We can't ignore them.
Right. Someone made the comment that you were so charming and comes through as so sincere and sympathetic.
Oh, thanks.
Thank you. Any advice for a young dancer to keep her body safe but progressing?
Cardio and Pilates. Pilates, bar fitness, and then making sure you're really working on your cardiovascular endurance. You don't have to run. You can do things like swimming, biking, elliptical is really great, but just making sure that you have the stamina. If you're tired after if you're winded after a 32 count petit allegro, you probably need to get into the gym a little bit more. But
Okay.
yeah, bar fitness, Pilates, cardio.
All right, I'm going to lean into the discomfort of asking this question personally. Pilates for men, something we should be doing?
100%.
Okay.
Pilates isn't just for women, but it's a great way to meet women. That's what I always say to the guys to get them into ballet. Like, hey.
Well, it is along the same line as people who don't understand that pelvic floor disorders can happen to men as well as women, and so I'm trying to artificially break through that misconception area there.
Yes.
Are bunions hereditary, and how do you treat them other than surgery?
Oh, I wish I had one in right now. There are little things called toe spacers, gel toe spacers that you can get that you put in between your toe. You don't have to get the ones that like strap onto your toe. That actually, I don't like that because it cuts off my circulation. I happen to not be wearing them right now, or else I'd pull them out and show you. But they're called toe spacers, gel toe spacers. They keep your big toe in better alignment. A lot of times bunions are hereditary. Sometimes it's coming from if you roll your arches a lot, then you'll get that too. And so it can come from just biomechanical issues. But you treat it whenever you're not dancing, wearing a stiffer soled shoe so that you limit motion through your foot. So you shouldn't be able to fold your shoe in half. If you can fold your shoe in half, it's not stiff enough. And then wearing those toe spacers every day is really, really helpful. You can't get rid of the bone. The bone's there to stay. Don't get rid of it. It's fine. Just change your footwear and wear a toe spacer. You'll be just fine without any kind of surgery.
Alrighty. For someone who loses 6 inches of height, hold on, I need to. Having inner bilateral thigh pain, would sports medicine treatment be helpful? Inner bilateral thigh pain in a person who lost 6 inches in height, would sports medicine be helpful?
Yes, because we can make sure you don't have stress fractures in your hips to start with. And then also we can really work on figuring out where that pain is coming from. And getting you, if it's something more mechanical, we can get you into some physical therapy. If it's an issue with the bones, we can start treatment with that too. But yeah, for sure.
All righty. Favorite question here. Women who wear high heels have ankle problems. That was actually a statement. Is there a safe height of heel that will not cause as many problems for the ankles?
You know, one of my mentors in college actually did a study on women walking on a treadmill in different footwear, and heels definitely were the least ergonomic. The lower the better for the heel. If you're going to wear a heel all day long, just be prepared, and try not to wear heels all day long. Save them for the special occasions. But the lower the heel, the better. In fact, sometimes I'll recommend to patients wearing a little kitten heel or a small wedge if they have plantar fasciitis, because it takes the pressure off. But the higher the heel, the more close to being in a point shoe you are. So the more you're going to pinch the back of your ankle. Also, the more chance that you can have a worse injury if you were to roll your ankle on the sidewalk. So the lower, the better. But if you want to wear those snazzy heels, I did work with a trauma surgeon who wore 6-inch stilettos to clinic every day, and nobody would ever give her a hard time because she scared the crap out of everyone. Tony McLaurin, she's pretty awesome.
She had 2 built-in weapons as well.
She had 2 built-in weapons.
Right, right. Well, and just to remind, especially the younger folks in the group, that men used to wear platform heels in the 70s, and they were high. They could be 5-6 inches high, with the significant difference being is that both the heel and the foot were equally raised up. So, but in any event, and having lived through that and maybe had 1 or 2 pairs of that, what I was always worried about was twisting my ankle.
Yeah.
Because you were up there on a wobbly rubber sole. Anyway, I digress. Do you work with work injuries, for instance, construction, plumbing, steel framing, etc.? So the blue collar work type of injuries.
Oh, absolutely. And actually, I had a dancer who's an electrician by day. Back in December, he was the Cavalier and the Snow King in an upcoming show, and he dislocated his finger. So I saw him unofficially on the weekend as like a impromptu training room, and I had to call my surgical colleague the next morning to get him right into a consult. We ended up, luckily, we were able to keep him dancing for 2 more weeks, which was the length of the performance series. But I had to, every show, I had to tape his tendon in place so that he could safely lift this other dancer up in the air, flip her around, all that other stuff. But yeah, I work with people who get injured from work all the time, all the trades. We see it all. We really do. Military people. I have a Marine who's like, let me show you how I load this artillery, and then you can tell me if it's safe. Like, okay.
Well,
so yeah.
And so along those lines, we're talking about what we do for work, but there are also those things that we do voluntarily, like going to the gym and doing squats with hundreds of pounds. And there's a question specifically about this knees for prevention. Should people avoid squats, or can you do them without going so deep, or should you avoid them completely?
It depends. As long as you keep your correct alignment. Sometimes it's helpful just to do a session or 2 with a physical therapist to make sure you're doing your squats correctly. I personally struggle to do squats correctly. It just has to do with my neuromuscular control and the flexibility of my ankle. Yeah, as long as you're doing it correctly, it's still safe to do. But again, if you just don't feel comfortable, or if you have some crunching in your knees, keeping your knee going no further than your actual toe is safe, as long as you're using, you're still in correct alignment, the knee over the second or third toe. That is still safe. It's a good way of building the glute strength. If you want a way around that even more, doing bar fitness, where you're really just sitting and your knee isn't even aligned with your toes up front. It's more aligned with your midfoot. But you're in that position on a bent leg for like a minute at a time as your working leg is moving all around, and it burns. You build so much endurance in those muscles. And so that's a really good one for building your glutes without having to, put a lot of stress on your knees.
All righty. So the other thing that occurs to me too is it depends, if you're talking about squats, what type of equipment you're doing.
Yeah.
Are you doing them within a piece of equipment, or are you doing them free weight?
Yeah.
And if you're doing the free weight, do you have a spotter?
Yeah, exactly. Yeah.
Yeah, I've been there, done that. Right. Nothing like the plates alternately flying off the ends of the thing.
We all learn.
There's a question here that I will follow up with to everybody. The question is, are there books or websites you would recommend to learn more about biomechanics and correct posture? And we'll research that. But doctor, if you'd like to send me any quick links, I'll get those out to the group.
Yeah, sure.
Coming to the end here, is it possible for a heel fracture to never heal and ultimately surgery be needed?
That's always it's always a sad day when the bone just didn't heal. But the good news is with surgery, it does. But then you have to do all that recovery. But yes, it is, especially the calcaneus, the heel bone, is a really high risk area. And so sometimes it doesn't heal, even if we throw a bone stimulator on it. But that's why we have our surgical colleagues. That's why we do the surgery. So it's okay.
All righty. I am so sorry that I can't get to all of these questions. Let me make a. Okay. Last one. Tanya, you're the lucky person. As a physician, or if you're injured, how do you feel about practicing self-healing and medication, or do you rely on another physician, or both?
I would say both. So the goals of physical therapy and my personal goals for my patients are to learn about their body. So it's an opportunity, right? I want you to learn about your body. I want you to learn the anatomy. I want you to learn the mechanics of how you move, because a lot of things come up in everyday life that you can actually treat on your own. We talk about self-treatment or self-care. Teaching you how to release a muscle with a lacrosse ball. Those are things that a physical therapist can do. I can also teach it to you in the office if we have time. But self-care is really important. When I start thinking like, hey, I need to work with another provider, is when there's something that I can't do to myself, like dry needling. My husband does cupping on me if I need it. But there are certain things where I'm like, I need someone to watch me, and I'm drawing a blank on how to strengthen out of this. I'm going to go see one of my physical therapy colleagues. I'll explain the situation. If it's still not getting better, then I'll see one of my colleagues in the office. But a lot of times the goal is for you to be able to not need us quite so much, to be able to take care of yourself on a daily basis. And, we'll be here if it's just not getting better, or it's a little bit of a mystery, or if it's something bigger that needs more involvement, like imaging or medications. Maybe it's because culturally coming up in the dance world, I don't really medicate very much because I want to be able to feel what's going on. I use medication. I use anti-inflammatories like an antibiotic. If there's a spot of inflammation that needs to be treated and cut down on, then I'll do a short course of it for all of my patients, including myself. But unless it's that really short period of time, similar to an infection, I'm not going to, I'm not necessarily going to treat it just for the pain. If it hurts that bad, I probably need a break, and I probably need to do something else.
Right. Dr. Barchi, thank you. This has been a fantastic Q&A and a great presentation. A number of people have asked, and we always ask if you could send on the PowerPoint. We'll convert it into a PDF and put it along with the video. I want to thank everyone for attending and Dr. Barchi for presenting. Next week, we're going to be talking about skin cancer, and next week is the final session for this series. Have a great evening, everyone. Good night.
All right. Thank you.